Okay, I think we can begin. Thank you, everyone who has joined us for our second global webinar, where we will be talking about the different ways that AI can help with identifying and visualizing patient care pathways, especially what are the benefits of using AI. And I am Mona Mihailescu. I am a real-world evidence analyst, and I am joined here by Pauline Lemay, who is a data scientist, and Marie Laurent, who is also a data scientist, who are also our experts in this field. So, a few words about us just before we dive into the subject. So Heva was created in 2005, so we are teenagers by now, we could say. We are a team that is steadily growing. There are 40 collaborators at the moment in different fields, such as project management, data science, pharmacoepidemiology, biostatistics, data visualization. For example, we have designers who we also thank for the beautiful slides. But if you want to know more about our team, you can head over to our website. It's very simple. Well, it's a bit small in the left-hand corner at the bottom. So it's hevaweb.com. And you can find out more about us, our history, our team. But mainly our field of expertise is analyzing real-world data, meaning particularly SNDS data, which is the French National Health System data. It is data that has been collected for healthcare insurance purposes, so for the reimbursement of healthcare provided to patients, which is secondarily used for different types of studies. It can be health economics evaluations, it can be epidemiology studies, it can be efficiency studies, and we have discussed this more in detail in our previous webinar, which is also available on replay on our YouTube platform. So don't hesitate to head over and watch it. So of course, part of this analysis is data visualization, and we strive to create innovative approaches and to create new ways to communicate data in much easier and robust ways. So as you can see, we have modern statistic methods, and we use also artificial intelligence tools. So that is all about us, very briefly. You can get in touch if you want to know more and know more about the services that we offer. But right now, I will hand it over to Marie, who will start to tell you about the subject of the day.
Hello, everyone. So yeah, we have 1 hour to talk about the care trajectories, the patient care pathways in a cohort. And the agenda today will be divided into 3 parts. First, we will talk about the steps, how to visualize the steps of care trajectory with the Sunburst and the sankey. Then we will see how to use the patient cards to compare some groups of patients in terms of care trajectory. And finally, we will focus more on treatment sequences with the TAC algorithm. The questions that we will try to answer today, or at least give some bit of answers, are how to visualize the care pathway for an entire cohort, which can be big, in a readable way, not just try to visualize someone but can't see anything in the graph. When we talk about care pathways, it could be something that happened before a diagnosis of a disease. It could be something that happened after the diagnosis, for example, the consultations, the biological test, but more specifically the treatment with all the questions about the treatment sequences. We will wonder if we can compare the care trajectories of different groups of patients. Is it possible to explain why there are several treatment sequences in the cohort, why some patients go toward one treatment sequences, while other go toward another treatment sequences. And finally, we will wonder a bit about the optimal treatment sequences, for example, with regard to the overall survival of the cohort. And now I will give the floor to Pauline for a short introduction and the two first sections.
Hello, everyone.
So today we are going to talk about care pathways and how to analyze and visualize them. So the first thing to know is that care pathway is always complex. We've got three main questions to answer. The first one is, who are the patients? So most of the time there are thousands of patients to analyze, which means a lot of information. Moreover, we have the question, what kind of events? There are lots of events, lots of kind of events that represent, again, lots of information. And the last question we have is when these events occur, when do they occur? And they occur at different time in a different order for each patient, which means that when we want to study the care pathway, we need to combine all these three dimensions to optimize them and to have something that is really easy to read and to understand. The first thing we want to do when we want to study care pathway is to represent all the different trajectories we can observe in the cohort. But the issue is that you get something that looks like the graph you've got on the right side of the slide, which we call a spaghetti graph. And yes, it is exhaustive, but you cannot see anything because there's too much information. So that's why we need AI, because if we do something very simple, as you can see here on the graph with our 5 bubbles of colors, you've got information, but it's not really informative because it's like the 5 main events of the cohort, and you don't need to analyze the data to know that these 5 events exist. So by using AI and visualization tools, we can get something that is still readable, but that is representative and informative. Indeed, studying care pathway is like making and using a GPS. This is not from us, this is from Professor van der Haas, who says that the first step is to map the pathway, all the different trajectories that exist. Then we need to follow the trajectory of each patient through the map. And then the goal is to track patients along their care pathway and to identify the key stages of the journey and to describe and analyze the time between the different events of the journey. And once you've done all of this, you can say that you've studied the care pathway. So the first part of our presentation today is to visualize trajectories, and especially the main care sequences. So we are going to take an example of the different steps that occur before lung cancer diagnosis. So let's take an example of 600 of patients who can have 7 events during the follow-up. So we can see 5 of them on this slide, and all of them have a different pathway, different events before the common event they have, that is the lung cancer diagnosis. For instance, the orange patient starts with a clinical examination, then he has a biopsy, and then he goes diagnosed, while the blue patient has 2 biopsies, then a PET scan, and then is diagnosed. Imagine you have 600 of patients on this slide, you can't see anything, you don't get any information. So the first visualization we suggest to use is the Sunburst graph. This is a step-by-step sequence visualization, which means that you try to represent all the patients of your cohort on this graph. How do you read this graph? You have to imagine that every patient is a sun ray of the graph. So the patient starts its journey at the outside of the graph, and then as long as he goes across the sunburst, he reaches the steps of his follow-up. The first step is clinical examination, then it is imaging, biopsy, and then it goes diagnosed. So where is the orange patients we saw previously on this graph? Here. So he starts with clinical examination, then biopsy, and then is diagnosed. The information you get at first sight is that this patient has a trajectory that is similar to 17% of your cohort, which means that there are 17% of the cohort that has the same events in the same order. However, you would like to know maybe what is the time between the clinical examination and the biopsy. And you can get this information with interactivity on the graph. And you know that in mean, for these 17% of patients, the mean time between the clinical examination and the biopsy is 42 days. And you can have more information, like who are these patients? They are 70% of males, and the mean age is 70 years old. Now we would like to know where is the blue patient that we saw previously also. He's here. So his trajectory is biopsy 1, biopsy 2, a PET scan, and then is diagnosed. And as for the orange patient, he has a trajectory similar to 17% of the cohort. However, the time between events is quite different. There's 28 days between the two biopsies and 45 days between the last biopsy and the PET scan. Also, the group of patients of the blue patient is quite different from the other trajectory we studied, because there's only 58% of males, and patients are younger because the mean age is 60 years old. So the Sunburst can be a solution if you want to visualize the main sequences and get the patient profiles associated to these sequences. You can easily also get the delays between events, and you visualize the entire sequence from the beginning till the end, or the diagnosis or the event of interest you want to study. However, there are some limitations to the Sunburst. For instance, you cannot really answer easily to the question how many patients had a scanner during their follow-up. Here you have to identify all the yellow boxes on the graph and to sum the number of patients that go through the yellow boxes to know how many patients had a scanner. Also, you can imagine that the more levels you've got on the image, the less readable the image is. So you need to limitate the levels you want to show and the number of events you want to represent so that the image is still readable. The next visualization we suggest to use is the sankey graph. The sankey graph has exactly the same information as the Sunburst. It represents the same informations, but it doesn't emphasize the same characteristics of the trajectories. Here, every boxes represents an event of the follow-up, and the arrows between boxes represent the flows of patients that go from one event to another. We've ordered the events by the number of visits, which means on the first column, you've got the first visit of the patients, on the second one, the second visit, the third visit, etc., until diagnosis. So we wondered the same thing than before, where are the orange and the blue patients? The orange patient is here, so he has the same trajectory as before, which is a clinical examination, a biopsy, and then he goes diagnosed. And as well as for the Sunburst, you can have information on the subgroup of patients that has the same trajectories and on the time between events of these trajectories through interactivity. We do the same for the blue patient that is here with its two biopsies, then a PET scan, and then he got diagnosed. Sorry. So the sankey is a solution that is complementary to the sankey, to the Sunburst. Sorry, because for the sankey, for instance, it is really easy to know how many patients had a scanner at their first visit.
that was not easy on the Sunburst, but here you have the information with the size of the boxes. Only with these boxes, you know how many patients had a scanner during their third visit. You also get the patient profiles thanks to interactivity as well as the Sunburst, and you get the time between events, and especially between one visit and another, also really easy. However, the limitation of the sankey is that it's only a one-step visualization, which means that when you're here, a patient with a scanner on their third visit, you know where they come from and where they're going to. They come from a biopsy, or an imaging, and they go to a PET scan or a biopsy, but you don't know where they came from at first, or where they're going to further. So you only have the one-step transition. You don't have the entire follow-up easily described. And as well as for the Sunburst, you need to limitate the number of events and the number of flows you want to represent, because it can quickly become eligible. The sankey is well used in the literature. Here you've got an example of a work of the Lille Hospital, who wanted to represent the care pathways of patients who had a pancreas surgery. So all the patients had a surgery at first step, and they wanted to know in which care unit the patients were going after this surgery. And at the end, they wanted to know if patients were able to go back home or if they died. So this graph represents a lot of information for a lot of patients, but it is really concise, and it synthesizes really well the information. So the two approaches are really complementary. The sankey has different flows. It shows the different flows, and you can easily know at each step how many patients went through the step of interest. However, it can be difficult to read when there's lots of events and lots of flows, and when and you don't get easily the entire history of future of the patients. While for the Sunburst, it's really easy to read when you've got few steps, and it is also easy, and it's emphasized on the main trajectories and the main sequences from the beginning till the end of the cohort. Once more, you've got to be careful on the number of events you want to represent, and it can be difficult to read when you want to count how many patients had a specific event whenever it occurs in the follow-up. The second part of our presentation today is to focus on comparing different trajectories, and to make groups of patients depending on the trajectory they can have. To do so, we are gonna keep on our example, and we're gonna observe, analyze what happens after the diagnosis by studying the consultations, the biological and the clinical tests, and the treatments. So the representation we use is a patient's card representation. Let's say that, let's take the example of a patient who has, so we're going to study the 4 items of care. The first one is imaging, the second one is biological examination, then specialized doctor's visit, and then the treatments. And for each time unit, we're going to say if yes or no the patient had the care item. So the first, the time unit, is 2 months duration. So we've got an indicator for month 1 and 2, 3 and 4, 5 and 6, etc., etc. So our patient has imaging for the first 2 months, then he has no imaging till the months 7 or 8, while he has biological examination from month 1 to month 6. And so once we've got this information in the databases, we convert this graph into a card, which is an images that we call a patient card. And what we did indeed is only converting cycles to squares, but it is much more easy to use in our algorithm because it looks like a matrix. And so for each time unit, you've got the indication, or if yes or no, the patient had the event of interest. And we do so for every patient in our cohort. So for every patient, we get an image that is the card of the patient. And once we've done this on all the patients of the cohort, the first thing we would like to know is, okay, what is the mean pattern? What is the mean trajectory of the patients of the cohorts? So we do the mean of all the images we had before, and we sum of the images one above the other. And the resulting image is a representation of what happens in the cohort. The darker the square is, the more patient have the events, and the lighter the square is, the less patient have the events. So we can see that you get a lot of information that is represented on this. First of all, you've got information item by items. For imaging, you know that the cohort has mainly imaging during month 1 and 2, and then 5 and 6, and then 9 and 10, while they have biological examination during month 1 and 2, and 7 and 8, with almost no biological examination during month 3 to 6. And you can also see the correlations between items on this graph, which means that you see it looks like the treatment and imaging are linked, are correlated, because you see that treatments occur almost at the same moment than image. But we would like to go a bit further and to know if there are some subgroups of patients that have different care pathways in our cohort. So we take the entire cohort and we are going to use algorithm of machine learning, clustering algorithm, which take all the images of all the patients and try to make groups of patients of images that are similar. So this is an unsupervised analysis, and it when we run it on the entire cohort, we got two subgroups. The first one is the mean card of the first subgroup is on the left, and the mean card of the second subgroup is on the right. And you can see that both groups have really different trajectories. The first group has imaging and treatments once month for 2 months and then stops and then starts again, while the subgroup 2 has imaging for the first month and starts treatment only after month 5. So you can, thanks to the algorithm, you can identify subgroups with really different trajectories. But there's another information that is that we can get thanks to patient counts. The idea is that in our databases, we've got lots of patients and data that is used for a specific purpose, and especially to make patient counts. So we've got lots of information. However, sometimes there are some information that are missing in our main databases. For instance, we don't have information on the severity of the disease. We know that the patient is sick, but we don't know how much he is sick. So we need to use another database that maybe concerns less patients, but that has useful information that we would like to have in the first database. For instance, here we have another database that where we only match several patients from the first one, but we know, thanks to this database, that these patients are severe from the disease they have. So we use the patient card of these two patients that we know are severe, and we say the algorithm, okay, look at the patient or the card of these patients, and we tell you that these patients are severe. So this is a trained text phase of the algorithm that is based on neural networks. And so we teach the algorithm what a serial patient pathway looks like. And once we've done that, we want to know if by using the patient count of these patients, maybe the algorithm could tell us if this patient looks severe or not. So we use the patient counts of all the patients to classify that we are not in our second databases, so that we don't know the status of the disease, and we show them to the algorithm. And the algorithm is able to tell us if the patient is sick, meaning that he has a pathway that looks like patient he has learned on, or if the patient doesn't look like this patient. And if the patient doesn't look like a sick person, sometimes it is because he's healthy, meaning that he has no event or almost no event, or sometimes it is because he's too sick and he has too many events to really look like a sick patient. So this is how autoencoders and algorithm on patient counts can help us to classify patients. To conclude, the patient counts are really useful because in one graph, you get the overall patterns and trends you can observe in the cohort, and that for different items of care, while for the Sunburst and sankey, you only have one trajectory. Here you've got 4 trajectories shown on one image. You get a visualization of the temporal evolution and link between items. The temporal evolution can be really, really important by studying stages of a disease, for instance. And you can identify subgroup of patients with different pathways, and also to classify patients you don't have the information on your first database. However, this analysis is still not widely used, so we need to explain very well what are the algorithm we use, how do they impact the analysis, and what is the importance of using and visualizing care pathways this way. I'm going to give the floor to Mary for the third part of the presentation.
So now we will focus on the treatment sequences. We will wonder what are the typologies of treatment sequences in our cohort and how many patients are in each of our treatment sequences. The algorithm we used to deal with treatment sequences in EVA is called the TAC algorithm, which stands for Time Sequence Analysis through K-clustering. With the TAC algorithm, the first step is to modelize the patient as a timeline. Here you have some example. This patient, for example, has a timeline from the beginning of the disease to 1 year later. And you color the timeline at each day by the treatment the patient was under at this day of the follow-up. So these patients start with a short period under what we call a drug holiday. It has no treatment at all. Then it has drug A, which is the blue, then drug B, which is the light and blue, then drug C until the end of this 1 year follow-up. And you do this with all the patients. For example, the second one has a bit more time under a drug holiday, then a short time under drug A, and the rest of the time of the follow-up under drug C. The TAC is a clustering algorithm. It takes all these timelines and gather them into groups of similar timelines. So here we have this first group with 3 patients, and we see our second patient here, which was gathered into this group of patients. The main advantage of the TAC is that you keep the real temporal vision, the temporality information in this timeline. You exactly know when does the patient start drug A, end drug A, start drug B, end drug B, etc., etc. Why do we need AI? because we could have a lot of patients, a lot of, let's say, colors on the timelines, different treatments. So a lot of possibilities, and we are on a temporal patterns, so we will not have two patients that will be the same. One patient will switch off treatment after 2 months, the other one will switch off treatment after 2 months and 1 day, the other one after 2 months and 2 days. So there is really a lot of possibilities. Moreover, we are on real world patients. So even if in theory the drug is supposed to be given every 21 days, in practice, one time it will be every 20 days, the other time 22 days, the other time 28 days. So there will be little time of noise in this patient. And we are on real life data, so we have to add to the noise of the patient the noise of the data, with sometimes missing values, for example. So we went into the toolbox of artificial intelligence to get an algorithm which will be robust, which will be flexible, which will be which can see the similarities between this patient instead of just saying, okay, all patients are different, I can't do anything with it. We need an optimistic algorithm that can see the similarities between patients and can extract information from all these patients that are totally different. The algorithm that we chose was the hierarchical agglomerative clustering, and it's the base of the TAC algorithm. The final image that is given by the TAC algorithm looks like this image on the right part of the slide. In this image, each line, really small as it is one of the timeline of the patient of our cohort. So here, for example, we have this patient which starts with 1 month of drug holiday, then 2 months of chemotherapy, and then trastuzumab until the end of the follow-up. And if we go in another line, we have another patient here, 1 month of drug holiday, 2 months of chemotherapy, 2 months of combination of chemotherapy and trastuzumab, and lastly, the trastuzumab until the end of the follow-up. In this image, every timeline in our cohort of 2,000 and 1,600 patients have been stuck together, one on top of the other, but they have not been sorted randomly. They have been sorted intelligently thanks to the TAC algorithm. The idea is that two treatment sequences that are really similar are just on top of the other, one on top of the other, where two treatment sequences, that are really different are really far from each other in this image. So the main idea is that here you have one image which is readable and which gives you the total overview of what's going on in the treatment sequences for your patient in your cohort. And it makes you realize a lot of things, usually. This is not a fake example. Actually, this image is the result of a study about a breast cancer cohort. So this is really chemotherapy, combination between chemotherapy and trastuzumab treatment and the trastuzumab treatment. The main quantified results that came with the study, and usually with a study when we're using the TAC algorithm, is the number of cluster that the TAC found in the cohort. So the number of different typologies of treatment sequences. Here there were 4 main typologies of treatment sequences. The main one being in group A, patients starting with 2 months of chemotherapy followed by trastuzumab. The second one was group B, group C, and the fourth one was group D. And we have one last group, which is group E. That's a typology of early treatment stuff. It represents 10% of the patients. And that's the patient that deviate from the recommendation, because when you start trastuzumab, you're supposed to take it during 1 year. So all patients here from group E have a stop in the trastuzumab treatment. There should have been an issue. We can go a bit further and have another quantified result with this curve that we added at the bottom of the TAC image, which we call the reportation curve. The idea is to get at each time of the follow-up the percentage of patients under each of the stage, each of the treatment in the cohort. For example, at time 0 of the follow-up, 100% of the patients were under a drug holiday. They have not been treated yet. Whereas if you look at 2 months of follow-up, 60% of the patients were under the blue treatment, so chemotherapy. Actually, you can draw a vertical line here on the TAC, which show that at 2 months of follow-up, that's patients from group A and group B that are under chemotherapy. And if you go a bit further, at 8 months of follow-up, we have 90% of the patients that are under trastuzumab treatment, and that's patients for group A, B, C, and D. This horizontal line on the TAC has been computed automatically by the clustering algorithm. So now we know that in our cohort, there are 5 typologies of treatment sequences, 4 that are normal, I would say, and 1 of early treatment step. And we can wonder, are the patients the same in these 4, 5 typologies of treatment sequences? What are the difference? Why some patients would go for the treatment sequences A, where there are some other will go for the treatment sequences B, etc., etc. To answer this question, we can go for just the simplest possible descriptive analysis and say, okay, what is the median age of patient in group A, in group B, in group C? What is the proportion of patients with diabetes in group A, in group B, in group C, etc., etc. The result we had on this breast cancer cohort is about men and hospitalization for cardiac event. In our 2,600 patients, we had 9 men. That's a breast cancer cohort. Among these 9 men, 5 were in group E, so the group with the issue, the group with the early treatment step. We wonder also about the hospitalization for cardiac events because trastuzumab is sometimes linked with cardiac events, or supposed to be linked with cardiac events. So we looked at each group, the percentage of patients that had at least 1 hospitalization for cardiac events. There were 1% in group A, B, and C, 3% in group D, and 5% in group E. All these results have been published first in a poster and then in a journal, in a peer review, in an article in a peer review journal. So you have the links here if you want to go a bit deeper in this analysis. For now, we just look at descriptive analysis to say, are patients different in one cluster from the other cluster, but we can go a bit further and use the cluster in really a statistical or machine learning model. For this, I changed the study case, and we are no more in the breast cancer, we go in the lung cancer. This time, the reference point for the patient, the time 0 of the follow-up, is the initialization of a nivolumab treatment. The TAC algorithm found 4 clusters. The main one, cluster 1 here, were made of patients mainly treated by nivolumab over the 2 years of follow-up. We selected patients that were alive, still alive 2 years after the initialization of nivolumab treatment. By using the statistical model, we found that patients from cluster 1 were significantly younger than patients from cluster 2, 3, and 4, and then patients from cluster 2 had significantly more brain metastasis than patients from cluster 4. So here the example is about age and brain metastasis, but it works with anything, comorbidities, gender, genetic mutation, the geographical region in which the patient is treated. You can really wonder, with all the variables you have in your database, why are there several clusters, and why sometimes there are patient difference in each of the clusters. This is also a published work in a poster and in an article in a peer-reviewed journal. So if you want to go a bit further, you can click the link here. Another example, going back with the breast cancer cohort, this time we do not just want to see the treatments in the cohort, we want to see the routes of administration. When trastuzumab is given as an intravenous treatment and when it is given as a subcutaneous treatment. So the reference time point is the breast surgery here. Here it's the 0 time in our follow-up, and we're 1 year later the surgery and 6 months earlier before the surgery. We had 2 cohorts, the adjuvant cohort, which has no treatment at all by definition before the surgery, and the neoadjuvant cohort, which started the treatment before the surgery. So this time, light blue is the chemotherapy, the medium blue, the normal blue is the intravenous trastuzumab, and the dark blue is subcutaneous trastuzumab. We still have our group D here of patients with an early stop treatment, but we focus more on group A, B, and C. Group A is made of patients that have only trastuzumab with the route of administration intravenous. Group C is composed of patients that have only trastuzumab with the route of administration subcutaneous. And group B has the 2 routes of administration. And we can see the temporality of the switch between the 2 routes of administration in the TAC. Here is the 4th month after the surgery, and here is the 8th month after the surgery. So most of the patients switches of routes of administration between the 4th and the 8th months after the surgery. So we could use the TAC to evaluate the adoption of a new route of administration. Here it was the subcutaneous trastuzumab. This is also a poster. The link is here. Another example, this time we focus on type of care and the difference, the type of cares that traditional hospital stay and hospitalization at home. We are on a cohort with patient that has a lung cancer. This time, the 0 point here in our timeline is the first time the patient had an hospitalization at home with the delivery of its lung cancer medicine in an hospitalization at home. And we were wondering, when this patient had this first hospitalization at home, did he stay in this type of care? Did he stay in hospitalization at home? Or did he switch back to traditional hospital stays? Or did he alternate between the 2 types of cares? So in this TAC, every color is kind of double. The dark one is for the hospitalization at home administration, and the light one is for traditional hospital stays. So if you see that in line 0 here, everyone is under dark color because it is our reference time point. For example, on the top of the TAC, we're on a patient treated by pembrolizumab. On the very top, patient switches to hospitalization at home settings and stays under the hospitalization at home setting. Whereas here on the middle, patient started the hospitalization at home, but switched back to hospital stays, to traditional hospital stays. And in the blue treatment, so nivolumab, we see again this patient that started an hospitalization at home, but switched back really quickly after less than 3 months to the traditional hospital stay. We have some patients that stay in a hospitalization at home, and we have this patient here on the very bottom of the TAC that alternate. There is 1 month of hospitalization at home, 1 month of traditional hospital stay, 1 month of hospitalization at home, etc., etc. So in this cohort, we can see the 3 type of alternating the three possibilities between hospitalization at home and traditional hospital stays. This is a way to evaluate the adoption of this new type of care, the hospitalization at home, and it could also be used to visualize the COVID impact on some type of cares. For example, we were wondering if this patient that had less than 3 months under hospitalization at home, is it during the first lockdown in France and the switch back to traditional hospital stay as soon as they can. This is also a published work. The link is here. One last disease. We are on the rare disease. This time, the Fabry disease, and we had all the patients with Fabry disease in France. This time, the reference time point on the TAC for all the timelines is not a medical event. It is a calendar date. So every patient starts here at the 1st of January of 2009 and go until the end of the year 2016. This is a way to use the TAC to visualize the impact of some dated events. The dated events could be the introduction of a new drug in the market for this disease, or a shortage or permanent withdrawal. In the case of the Fabry disease, there were a shortage of the main drug used in this patient in mid-2009, a shortage of the light orange drug here. And actually, we waited until mid-2010 to see a big impact of this shortage for the treatment sequences of the patient, because all these patients here and here had a switch from the light orange treatment to the dark orange treatment. It's also really visible on the reportation curve under the TAC here, with the big decrease of the proportion of patients under the light treatment and the increase of the proportion of patients under the dark treatment. We also see on the TAC what happened at the end of the shortage. Especially these patients from group B went back to the first medication, to the orange light medication after the shortage. In Fabry disease, there were another medicine, another drug. So patient had a drug after the shortage, during the shortage. But we have another example where during the shortage, there were just a blank period with drug holiday because people had no more treatment at all. This is a published work and the link is here. Another thing that can be illustrated in this study about Fabry disease is to compare the treatment sequences between subcohorts. So for example, we can wonder, are treatment sequences the same for male and female? Our treatment sequence is the same for younger patients and older patients. In Fabry disease, we did it for male and women. So we just took the treatment sequences, like these timelines of male, and put them on this side, and took the timelines of female and put them on this side. And we did not see real differences of treatment sequences between these two groups. But we did the same for patients with the cardiac variant, and patients without the cardiac variant. And this time we see differences in the treatment sequences, especially this group D with a lot of drug holiday and no treatment at all is really larger in the cohort of patients with a cardiac variant. And that's possibly due to the inclusion of patients in clinical trials. So this technique where we split our TAC, our image, into two images according to a patient characteristic could be done according to a patient characteristic, according to comorbidity, but it also could be done to compare the treatment sequences for patients included before 2020 and after 2020, or to compare the treatment sequences according to a region. Are patients treated the same in Paris than in the rest of France, for example? This time it's not a published work, it's totally fake data, but we will have published work one day on this technique. And it was really important for us to show you what you can do to go a bit further. The idea is to talk about optimal treatment sequences. This time, the treatment sequences is a variable in a model, for example, a Cox model or another statistical or machine learning model. And the idea is to use this model with an outcome, which can be the risk of relapse or the overall survival, to say that one treatment sequences, one group is linked with a better overall survival, a lower relapse risk. So here you have fake results with the reference for group A, and actually in these fake results, group E have 1.8 more risk of relapse in the year following these dates, etc., etc. We have a video on YouTube about the TAC algorithm. It's 3 minutes long, I think. We have it in English and in French. So if you want to share in another format, it's possible. And to have a bit of a summary about the TAC algorithm, the main idea is to have an overview of the treatment sequences in the cohort, so the treatment switches, treatment-free intervals. It can help you to visualize the pathway that deviates from the recommendation. It also helped us to consolidate the cohort definition. Sometimes we directly see on the TAC there is a pathway which is from another disease, and we know that we do not want this patient in our cohort. It allows us to visualize the shortage, the permanent withdrawal, or the introduction of a new drug impact on the treatment sequences. We can analyze dose variation, anti-cancer administration routes, alternating between traditional hospital stays and hospitalization at home, and it can help to answer the questions had patients with different treatment sequences had different characteristics. Where does the different treatment sequences comes from? And is there treatment sequence which is linked to a lower relapse risk, to a better survival, or another outcome? As a conclusion, we talk about identifying and visualizing the care pathways. We saw mainly 4 tools for visualization. First, the sankey and the sunburst are really about trajectories, the different steps in the pathway, the order between these different steps. Then we saw the patient cards, which is about the evolution of care items used over time, item by item, and all the toolbox that go with the patient cards. We can do a lot of things with the patient cards in an analytical way. And finally, when you focus really on the treatment sequences, you could use the TAC algorithm, and again, all the toolbox that is around the TAC algorithm about which are the patient in each of the cluster and what is the optimal treatment sequences.
Okay, so now we have well, technically less than 5 minutes left, but we will take as many questions as there are. Okay, so normally now you can.
Yeah, you should. Can you hear me now?
Yes,
Yeah.
perfect.
Can I switch also on my camera? No. Okay. Good. Yeah. So I learned a lot, but at the end, if you see different sequences, at the end you want to know, okay, which of the patients have lived longest. So you showed, of course, different treatment sequences for non-small cell lung cancer, and you showed also different any other variables which can be considered, like home care or hospital care. But at the end, I would like to know always, okay, what was the best at the end for the patient, and this is, yeah. Yeah, I haven't seen anything, so I do not learn, okay, what is exactly this here. So it starts with drug holiday and then chemotherapy followed by trastuzumab, and I know, okay, these are the different proportions, but which of the patient cohort did best at the end with regard to the outcome, so the overall survival? That's the question.
Yeah, this is the big question. I agree. That's why we wanted to talk about this slide, these optimal treatment sequences, even if it's not published yet, because it's the idea to say, okay, we use this cluster, these different treatment sequences to add them in another model, which will say, okay, group A is the best treatment sequence with regard to the outcome, overall survival. And you have to choose the outcome and then enter the clustering results in the model to get this answer. But sorry, you'll have to wait a bit more time to have a published work on this.
Okay, so I will wait for the publication then. Thanks.
Are there any more questions? Okay, if there's nothing more, we will end the webinar here. Thank you very much for having joined us. There will be a replay, as I was saying at the beginning, so you will be receiving the link via email. There was a question about whether the slides will be shared. I think that would be okay from our side. We will check before that there's no sensitive information, but normally we should be able to send it to you if you would like that. And of course, don't hesitate to get in touch if you have any further questions, if you have any studies that you're interested in. And also you can follow us on LinkedIn, on Twitter, and you will be updated whenever there's a new publication, our future webinars, our newsletters, our Congress participations, and many more fun activities. So thank you everyone. Have a good evening or good day, depending on where you are. Hope this was helpful and interesting.
Bye.
And hope you can join us for our next webinar. Okay, bye-bye.
Bye. Bye. Thank you.